Thank you, Ajay, and the scientific committee, and welcome all colleagues and friends from the ophthalmic community at this prestigious All India Ophthalmics Society conference. We'll just, in short, try to go through, as Ajay has planned the program so well, the role of for pharmacotherapy, and the initial pharmacotherapy which we'll discuss is the role of anti-VEGF, which you all know, in diabetic macular edema. How does it improve our visual outcomes? It's important to understand that diabetes is, of course, DME is the most important cause of visual impairment in diabetic retinopathy, or for that matter in diabetics. And you can achieve optimal glycemic control, normalization of blood pressure and lipids, and of course prevent the progression of retinopathy. And laser by itself, as I've shown here, laser by itself can only does not improve the vision. It can halt progression of further worsening of vision, or it can prevent the further worsening of vision. It does not generally improve vision if you do only primary laser. But as opposed to that, if you give anti-VEGFs, you can actually improve vision, and that's been shown by various studies which Neeraj just told you. So OCT patterns has already been shown to us, and OCT is a very important quantitative tool to diagnose the initial picture of the edema, the kind of edema, and also the serial follow-ups depending on your treatment. And you can also know that the patient is going into treatment success or treatment failure, or a poor responder. So besides the OCT, do not forget the role of fluorescein angiography, though it's not so important now, but it still holds a great role. And the important thing about fluorescein is it tells you the baseline status. So at baseline, probably it will be a good idea to get it done. The healthy RP thin retinas like myopics, the OCT may sometimes be very normal, or may not give you the proper amount of leakage which is there. So that in those cases, fluorescein really helps. Now, to differentiate between focal and diffuse edema, it's very important to do a fluorescein, because there's level 4 evidence from the American Academy of Ophthalmology that fluorescein tells you the difference between focal and diffuse. Diffuse is a more severe form of DME, which may require more intense treatment in the form of not only anti-VEGFs but other treatments also. It does not respond so well. So if you have a treatment failure, often you may be having the diffuse edema with an attached hyaloid, with the PVD has not occurred. And also to look for macular ischemia. Ischemia, the perfusion will only be known not by OCT but by the fluorescein. So as Ajay had just mentioned in the initial lecture, that if you've got a poor responder, it may be because the FAS is broken and enlarged. So the ischemia of the macula, as well as peripheral ischemia. Now there's a lot of talk going on about wide field imaging. And to plan the treatment initially, and also as I told you, if ischemic maculopathy is present, probably anti-VEGF, most of the reports show that they worsen the edema, they worsen the vision, because there's an element of vasoconstriction, though some reports state to the contrary. But there's evidence which is going in favor of ischemia more, as well as for a research tool and as well as clinical trials. So here you can see a wide field photograph. Now there are anecdotal evidence that you should do a wide field angiography. It's not that everybody should do it. The standard angiography is good enough, and you can ask the patient to look at various directions, take a montage, and that should be sufficient. Also, when you buy these very highly complicated machines, very costly, you have to have followability and servicing, which is often lacking in our with the trading community. So that's very important to know that. So if you've got peripheral ischemia over here, it's generally picked up very well at the same time with a 200-degree field, and the advantage is that the 200-degree field is seen at the same time. It's a wide field picture taken instantly when the dye is transiting through the periphery as well as the center. So peripheral ischemia plays a role by causing an increase of VEGF release and then contributing to the macular edema. So what they say is you target your laser only to these ischemic areas, not a full scatter. So the healthy retina is not targeted, and only the ischemic pathological retina is targeted in the periphery, which may also help in poor responders. So here you can see the patient with central involving DME in the previous picture, and received Lucentis or ranibizumab, and within 2 weeks you can see the response. The edema is down. In fact, the disc leak also appeared to be down. The leakage from the disc was reduced. The macular edema is reduced. Of course, these ischemic areas won't go away with the anti-VEGF. For those, you have to do a laser therapy. So laser also plays a major role. So that showed you the effect of anti-VEGF in the case of diabetic macular edema, but using a wide field angiography as a tool for diagnosis. So just to recapitulate quickly in 2 slides, the various studies which Neeraj has so nicely shown. The protocol I is the study which we should know, because it combined ranibizumab with deferred laser at focal or grid depending on whether it's focal or diffuse laser edema. If it's focal edema like circinate rings or leaky microorganisms focally present, you might like to just put focal laser. That's a form of a laser also, which is called focal laser. But grid is modified grid as per ETDRS. You put a grid of spots to spare the central 500 microns, give two spot sizes of 3000 microns away on each side, temporal, superior, nasal, and the modified grid avoids the papillomacular bundle. That may be reserved for the diffuse edema. Rise and Ride were also studies with recently. So this sheet tells you about all the ranibizumab studies. The Rise and Ride was the monotherapy study, this was a combination study, and the READ was also a combination study. The READ trial basically told us that if you combine with laser, the residual edema is reduced, as well as the frequency of injections, which is very helpful to the patient, is reduced. The BOLD trial is already known for bevacizumab, and bevacizumab is a very potent drug, Avastin, which is highly effective for reducing the macular edema and economical for a country. Aflibercept, which has just come in, has 3 trials to its credit. The Da Vinci, the Vivid, and the Vista. The Vivid and Vista showed that 2Q4 and 2Q8, that is 2 milligrams at every 4 weeks and 2 milligrams of the aflibercept at every 8 weeks. They found that 8 weeks was similar to 4 weeks, and in fact it was superior to laser. So they found that bi-monthly dosing, which is less economically, it is more economically beneficial, as well as the patient follow-up may be reduced because you don't need to inject every month. And this is just to show you a combination treatment of patient with central involving diabetic macular edema, in which we've got central involving DME, which will be shown to you in the OCT also very clearly, and the pattern scan laser done. And at 1 month you can see the edema is reduced. This is the same picture. At 1 month, the first injection itself has brought the edema down on one side. The cystic fluid has come down. Even the central serous detachment has kind of collapsed. And the patient is tending to improve both in the form of OCT as well as probably the vision was also improving. So the strengths of the anti-VEGF agents in DME are very important. Ranibizumab has a small molecular weight, so probably a better retinal penetration. It's genetically engineered, so it's probably the least antigenic. It's got a very short half-life of 6 hours. Now we've got an extrapolation from the CAT showing that bevacizumab may be as good as ranibizumab, and the protocol T is actually will come out. The 2-year trial will come out with the results more accurately. And the VEGF trap is got powerful VEGF binding capacity, but 140 times more than that of ranibizumab, and it inhibits not only VEGF-A but B and placental growth factor. It's got a bi-monthly dosing, as I told you. 2Q8, which was in the Vivid Vista study, showed that it had a equally effective as monthly injection. It's got a safety profile quite similar to that of ranibizumab. And a protocol T, actually the 1-year data is out, which is showing that it's about the same as ranibizumab, or probably a few letters better on ETDRS, because ETDRS we do the visual letters, unlike the Snellens where we do the lines. And for studies and the trials, probably the ETDRS is better, but for routine OPDs and all, Snellens may be okay. So refractive DME is something which I've been hunting for exact definitions, the ETDRS, right up till today from the drcr.net. But whatever little I could get, I could make out was that it's defined by drcr.net as post anti-VEGF at 3 months or 13 weeks, which is about 3 months. The visual acuity drop is 10 letters or more worse than baseline. That's when you call it a treatment failure, or the OCT thickness is going beyond 250. There is clinical edema on your 90D or a 2070D biomicroscopic examination. You have laser already given. That is, you lasered the focal MCAs and the leaky capillaries or the irmas. And at 12 to 13 weeks, they define it as 13 weeks, just completing 3 months. That's when they say when you have all these things in place, then the patient can be described as a treatment failure. But I suppose there will be a better definition required for that. So when do you have a treatment failure, what can you do? You can add steroids. Transferrin is the most potent drug, but of course dexamethasone and fluocinolone, for which we should give credit to Professor Mohd Gupta and his team. They've done a lot of work on Illuvin. It's a little more expensive, but I think it will be covered by the insurance companies and the CGHS. But IVT is helpful because it's very potent and quick acting. So it brings down the edema. You can give 1 to 2, or to prevent the glaucoma rise and the cataract, 4 milligrams may not be given. To check the glycemic control, it may not be good. Rule out glitazones in the therapy. Do the fluorescein angiography, which is sufficient. In case you have the facility in some center where you can go and do it, you don't need to have this machine for yourself. You can do the ultra wide field imaging also for peripheral ischemia. And OCT for interface disturbances which cause traction. So summarizing a little bit, anti-VEGFs continue to stay mainstay, but there are other angiogenic pathways also. So you have to understand that there are other pathways, not only anti-VEGF. Anti-VEGF is over here, bevacizumab. But the other anti-engineering pathways are tyrosine kinase inhibitors like those drops which are going to be available, pazopanib drops, and angiopoietin inhibitors, and mTOR inhibitors, as you've heard of, sirolimus, and which are drug-eluting stents and all. So upcoming research is a T, which I just told you, ranibizumab, bevacizumab comparison with aflibercept, the wide field imaging, which I just told you, and finally cataract, if it's mild, moderate, and you've got DME associated with it, you could do a laser if the media permits, and anti-VEGF or steroid should be given about 10 days to 2 weeks before. Steroid may be very useful because it stays longer, the effect stays longer. And if the cataract is extremely dense, you could give a same intravitreal VEGF or anti-VEGF for a steroid, but either or you could do a subterenous, which may be less effective, but still can be given as a pre-cataract surgery injection of steroid. Option is giving it on the table also. So final recommendation is all this which I just told you, which we just control, and non-center is laser, and fifth central 500 microns not involved, center involving it. And if the poor VEGF, you can add laser, steroids. Ischemic maculopathy, avoid anti-VEGFs, use steroids because the anti-VEGFs may worsen the retinopathy. Refractory edema, if there is traction in hyaloid is thick, and especially if you've got vitreomacular traction, those are the cases which should be operated for surgery, not the till date, not the ones without the traction. And minocycline is an antibiotic, also anti-inflammatory. It decreases the microglial activation, which I just told you about, tyrosine kinase and mTOR inhibitors. And all these procedures, laser, anti-VEGF, OCT and all, is not a one-time procedure. It requires repeated serial follow-up. Thank you.